All right, we have a very important topic today, and that's the care of the patient with a neurologic injury. And when I say neurologic injury, it doesn't necessarily have to mean a traumatic brain injury. The principles for the care of a patient with a neurologic injury share some commonalities, and that's exactly what we're going to be doing today. It is estimated that 71% of traumatic brain injuries, however, are for patients with severe injuries necessitating critical care monitoring. Critical care nurses deliver numerous interventions when caring for these critically ill traumatic brain injury patients. This presentation attempts to summarize all the care of a patient with a neurologic injury. So I begin by posing this question. You see this picture, and what would happen if we squeeze two more people and then close the doors? Could you please indicate your responses in the chat box? What would happen if we force two more people and then close the door to this car, to this van? Okay. And Amy said it will become congested. What else? And the, the van can't be closed. There's going to be a severe congestion, or the windows probably might break, wouldn't it? All right. So the reason why I'm talking about this is because of the fact that this concept that you will see over here is similar to what we're going to be talking about today. Okay? So I see all your responses, and thank you very much for participating. So I'm now going to relate this particular situation to a physiologic situation that occurs whenever there is a neurologic injury. Now, we have what is called the Monro-Cali hypothesis. The brain occupies about 80% of the space within the cranial vault, with cerebrospinal fluid and blood occupying 10% each respectively. These volumes are relatively consistent and result in what we call a normal intracranial pressure. So let me just pause a little bit to illustrate. And now you have a blank screen because I'm now going to illustrate what happens when we have an increase in intracranial pressure. So we said that this is a vault, the cranial vault, which is rigid. We call this the skull. And within the skull or the cranium are three occupants. And these occupants are 80% the brain tissue itself, and 10% each is going to be your cerebrospinal fluid, and the rest is going to be blood. Okay, so if we were to increase the capacity or the area where the brain resides, such as what happens when the brain inflames as a result of injury, what is going to happen? So let me just go ahead and change the color over here to make sure that we delineate what's happening. So I said that if the brain swells or increases its area, what happens to the amount of cerebrospinal fluid that's going to be present in the brain? May I have your answers? What happens to the amount of cerebrospinal fluid? Okay, so there's going to be a decrease in the amount of cerebrospinal fluid. All right, so why is that significant then? What is the significance of cerebrospinal fluid? Well, the significance of cerebrospinal fluid in this particular instance is that the cerebrospinal fluid is the one that actually supplies glucose to the brain. We all know what happens when there is no glucose. There's no fuel for energy. And therefore, what happens is all the mechanisms that are supposed to be present, such as the sodium-potassium pump, will now decrease or fail. And therefore, the evidence of hypoglycemia within the brain tissue is going to be evident. Now, what is the role of blood? Okay, so the same thing would happen with the blood supply. There will be a decrease in the blood supply. Well, for obvious reasons, what's going to happen is that there's going to be, number one, a decrease in oxygen supply into the brain. And thus, what happens? The brain now relies on non-oxygen as its main fuel. And therefore, it will result in another byproduct. Thus, all these particular physiologic changes that occurs with an increase in intracranial pressure is going to be evident in a patient that has a traumatic brain injury. So remember that the largest of these is brain tissue. I said that the brain tissue is 80% of what occupies the cranium. And unfortunately, the interventions that we do to correct the situation whenever there is a decrease in intracranial pressure does not affect the brain a lot. So let me repeat that. The largest of the tissues or the occupants of the cranium is the brain tissue. Is the one that traumatic brain injury interventions are least able to affect directly. So therefore, whenever we have a traumatic brain injury, we have to act real fast in order to prevent the complications that I have mentioned. Now, the other complication that is worth noting is that whenever we have an increase in intracranial pressure is this. So if this is the cranial vault again, there's going to be swelling of the brain. And whenever there's swelling of the brain, there's going to be an increase in intracranial pressure. This pressure has to be vented. And therefore, in the attempt to vent the pressure within the cranial vault will find the least resistant area. And what is the resistant or the least resistant area? Right over in here. This is the foramen magnum, the opening of the skull that leads to the spinal cord. And thus, what's going to happen? It's going to press on the areas that are going to be in the lower portion of the brain. And this process is what is known as herniation. Enoch is right. This leads to the herniation or the pressure finding the area of least resistance. All right. So there are other things that are going to be important within this particular slide. And so let's go back to the slide. Let me just erase all ink and go back to this. So the Monroe-Kenley hypothesis is what we talked about, that whenever there is a increase of one element of the brain, the cranium, I should say, there's going to be a consequential decrease in the other. There are also other interesting facts that we need to remember. And the first one is that the brain normally uses 20% of resting cardiac output. It requires 750 cc's of blood flow per minute in order to maintain homeostasis. And of course, it extracts nearly 40% of oxygen that it receives. So it is highly dependent, therefore, on circulation in order to maintain its oxygen supply. Now, as you could see in this illustration, therefore, there is a force that is going to bring blood into the brain, but there's also a resistance in the brain in the form of intracranial pressure. So the balance between the two is what is known as cerebral perfusion pressure. Cerebral perfusion pressure. Okay? All right. I wanted to pause a little bit to see if you have any questions at the moment before I proceed. None? Okay, so let's go to the next slide then. And this next slide talks about cerebral perfusion pressure. What is cerebral perfusion pressure? It's the amount of pressure that's needed to maintain a blood flow to the brain. It is regulated by two balancing or opposing factors, I should say. One is the mean arterial pressure, the one that's driving blood into the brain. And the other one is the pressure that is exerted by the cranial vault in the form of intracranial pressure. So it is actually represented by a formula, and that formula is mean arterial pressure minus intracranial pressure is cerebral perfusion pressure. Anytime you're working with a patient with a neurologic insult or neurologic injury, you need to make sure that you know how to calculate cerebral perfusion pressure. So cerebral perfusion pressure, again, is the amount of pressure needed to maintain blood flow to the brain. And in order to find what mean cerebral perfusion pressure is, we need to find the mean arterial pressure and the intracranial pressure. So let's talk about the mean arterial pressure first, right here. Let's talk about this MAP. So when we talk about MAP or mean arterial pressure is actually a product of the systolic blood pressure and the diastolic blood pressure. It is a measurement explaining the average blood pressure in a person's blood vessels during a single cardiac cycle. Now, mean arterial pressure is significant as it measures the pressure that is necessary for adequate perfusion of the organs of the body. In fact, whenever you're taking blood pressure, you should always calculate the mean arterial pressure. And it's a good thing because our machines now will show the MAP in parentheses. And this is significant because this is a better gauge of tissue perfusion. It is considered to be, by many, to be a better indication of perfusion rather than merely relying on the systolic blood pressure. It is vital to have a mean arterial pressure of at least 60 millimeters of mercury to provide enough blood supply to the coronary arteries, to the kidneys, as well as the brain. Let me repeat that. Whenever you are taking a blood pressure, don't look the systolic blood pressure alone as an indicator of tissue perfusion, but rather you need to look at the mean arterial pressure to be the manifestation of perfusion in vital organs. You have to have at least an MAP of 60 millimeters of mercury to provide enough blood to the coronary arteries, to the kidneys, as well as the brain. The normal MAP is a range, and this range is between 70 to 100 millimeters of mercury. That is exactly what you want to have as a normal MAP. Whenever we have a deviation from this mean arterial pressure for prolonged periods of time, it can have a drastic effect on the body because of obvious reasons that I had mentioned, that there's going to be a decrease in tissue perfusion. So whenever we're looking at mean arterial pressure, then the formula for it is systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. Okay, so example, when we have a blood pressure of 130 over 73, so let's put that into a formula. 130 over 73. So 130 plus 70, what is happening here? Times 2 divided by 3. That would be our mean arterial pressure. So what would be our mean arterial pressure over here if you work it out? Well, it's going to be 92 millimeters of mercury. Is this normal? Yes, it is normal, because you remember we said that the normal is anywhere from 70 to 100. Correct? All right. So before we go to the calculation of cerebral perfusion pressure, let me ask you this. Okay, that's very good. So we had a question over here. A patient's blood pressure is 160 over 100. What is the mean arterial pressure? And those of you who responded, which was 11 of you, said that it was 120. Okay, so this is how you responded. Everybody got it correctly. Wonderful. So the correct answer is 120. Now, is this good or bad? Is this good or bad? Okay, so some of you are saying it's bad because it's outside of the normal, right? It is too much pressure. So the risk over here is that there's going to be an exaggeration of pressure, and the likelihood of bursting arterioles in the brain is going to be very high. So a low mean arterial pressure is bad. A high mean arterial pressure is also bad. Okay, so let's look at the going back to cerebral perfusion pressure now. right? Whenever we are trying to evaluate what is actually going on in the brain as far as circulation is concerned, the formula then is the mean arterial pressure minus the intracranial pressure. Now, the unfortunate thing is that we usually have to measure intracranial pressure by having a ventriculostomy or a intracranial pressure monitoring device connected to the brain. And we don't always have that. However, ICP, as we remember in the first slide, we should have a intracranial pressure of 0 to 15 millimeters of mercury. So you could just imagine, therefore, that with an increase in intracranial pressure and a mean arterial pressure, we're going to have a abnormality in cerebral perfusion pressure. So in order to enable the intracranial pressure to remain within the normal limits, any alteration in the volume of one of the above components of the cranial vault, meaning to say brain tissue, cerebrospinal fluid, and the blood, must be offset by a reciprocal change in the other two. This summarizes the concept of Monro-Kelly hypothesis. Okay, so let's move forward. I have a question over here. A patient's blood pressure is 160 over 100. Okay. His ICP is 17. So let's say now that we have a way to measure the ICP. Now, what would be the cerebral perfusion pressure? All right, very good. A lot of you answered that. I mean, all of you answered that correctly. 103. Very good. So our mean arterial pressure was 360, right? Oh, 160. And therefore, 120 minus 17. The 120 is the mean arterial pressure, and 17 is the intracranial pressure. That would result in 103. This is very, very high. So if this is very high, what is going to happen? What happens when you have an increase in cerebral tissue perfusion? Is that good or bad? Well, let's find out. Okay. So supposing that this is brain tissue, and these are the blood vessels or the arteries. If I increase the brain tissue, notice what's going to happen to the blood vessel, to the lumen of the blood vessel. It will decrease the lumen of the blood vessel. And therefore, there's going to be less circulation that's going into the brain. Okay? Now, that also is going to be my next question. Now, in patients with brain injury, which one is a better blood pressure? 120 over 70? Or would a blood pressure of 160 over 90 be better? Which one of these two blood pressures would you rather have in a patient with an increased intracranial pressure? Okay, Solomon said 160/90. How about the rest? Sharon said 120/70. Eileen said 160/90. Okay, great. So let's think about it. If you have a narrowed blood vessel, would you be able to maintain circulation? The question should be, would you require a greater pressure to move blood into these narrowed vessels, or would you require a lesser pressure? Would you require a higher pressure or a lower pressure to move blood to constricted arteries? A higher pressure. So actually, you need to maintain a higher blood pressure in patients with traumatic brain injuries. So I used to work in trauma resuscitation, and I had a patient that was a motor vehicular accident. I think he was in a motorcycle crash. And when I brought him to the CT scan, his blood pressure was being maintained by dopamine. And I left him with a blood pressure of 160/80. So I was called back to the resus unit for something, and I had to go, and I left the patient with the CT scanners, and I said, could you just please watch my patient, make sure that he's going to be okay. And I left him, and I went back to the trauma unit, and I returned shortly, not even 3 minutes. 3 minutes later, I go back to CT scan, and my patient was having a seizure. And I thought, oh, what's happening? And I look at the blood pressure, and the blood pressure had dropped down to 110/70. And I said, what happened to the blood pressure? And the CT scan nurse said, why are you worried about the blood pressure? The blood pressure is normal. I said, no, it's not normal. It's not normal for this patient. He's not having adequate cerebral tissue perfusion. The reason is the patient's brain is vasoconstricted. We need to have a higher blood pressure. See, a lot of times nurses think and look at the number and they see that it is a normal number, but they don't understand what is happening to the patient. You always need to evaluate it based on the picture that is going to be at hand. Okay? So that's the concept that we need to remember whenever we're taking care of patients with increased intracranial pressure. And that's exactly what we're going to learn today, how to deal with a patient with an increased intracranial pressure. So let's move on to the pathophysiology of traumatic brain injury. I want to discuss the initial stage of traumatic brain injury. The initial stage results from direct tissue damage. And as a result of direct tissue damage, there's going to be an impairment of autoregulation of cerebral blood flow along with disordered metabolism. We talk about that, right? There's going to be decrease in glucose supply. There's going to be decrease in oxygen supply. This state, similar to ischemia, is going to lead to the accumulation of lactic acid. It also will therefore lead to an increase in cell membrane permeability and subsequently edema. Dr. Tom, what do you mean increased cellular permeability? So I'm going to draw a cell. So if this is a normal cell and the cell membrane is semi-permeable in the sense that it will allow for some elements to go in and it also allow for some elements to go out. Now, if I were to increase the size of this cell, so I now increase this cell to this much, does the cell maintain a thicker membrane or a thinner membrane? When you stretch a rubber band, does the rubber band become thinner or thicker? Aha. So if it is thinner, it therefore will now lose its selectivity in allowing for items or substances to go to it. So there's going to be an increase in cellular membrane permeability, and therefore it will increase edema even more. And since anaerobic metabolism means to say that we're no longer relying on oxygen. If anaerobic metabolism is present, it cannot sustain the demands of the brain. And therefore, ATP stores are going to be depleted. What is the result when you don't have ATP? We will now have a failure of our ionic pumps. An example of that ionic pump is the sodium-potassium pump. And these are pumps that are essential for maintaining adequate homeostasis. Now, the second stage of this cascade, or this pathophysiology, is characterized by excessive release of neurotransmitters. What are the functions of neurotransmitters? They're supposed to transmit impulses from one axon to another, right? So when you have an excessive release of neurotransmitters, examples of that would be glutamate and aspartate. These are going to increase calcium and sodium channels, and it will therefore release enzymes such as peroxidases or protease, which triggers the apoptotic cascade and therefore leads to membrane degradation and cell death. All right, so let's go back to that one. What in the hell did you just talk about? Well, let me see. Let's go back to basic cellular physiology. If this were a cell, now there is an area, right? The nucleus right over here. But there's also little packets like this one. And these ones are your peroxidases. These are enzymes. And these enzymes are supposed to, respond to an inflammatory process. So let me just change my color right over here. All right. So this is how the body responds and the importance of peroxidases that I was talking about, and phospholipase, any ACE or an enzyme. So supposing now that a microorganism enters the body and it enters the cell recognizes it as a very foreign matter. And therefore, what's going to happen is it's going to release or burst this particular packet over here, which contains the peroxidase. By bursting, it kills the cell itself, but it also kills the invading microorganism. All right. So in a traumatic brain injury, there's not an organism that is coming over here, but rather because this swells, what's going to happen is this now breaks. And when this breaks, what does it kill? It kills the cell itself. This is what we call apoptosis, or the suicidal killing of the self in order to maintain homeostasis. This is actually what happens whenever you have a massive injury. And this is what is known as your, what do you call that? Your catecholamine surge. That's what I'm trying to remember right over here. And it doesn't only occur in patients with traumatic brain injury. It could occur, for example, with sepsis, which would eventually kill the patient. Okay, so we have now talked about the pathophysiology of traumatic brain injury. And now let's segue into how to treat it. And the interventions to manage TBI is going to be remembered well by the acronym HEAD, HEAD. This has been developed to help practitioners like you and anybody that's involved with the care of the patient to manage patients with traumatic brain injury in a systematic manner without leaving any details. It has been observed that protocol management of severe brain injury in patients requiring ICU has led to favorable outcomes. So, these interventions to manage traumatic brain injury now includes hypotension for H, hypoxia, hyperthermia, hyperglycemia. So there are the 4 H's that you need to remember. E stands for elevation of the head, A, avoiding agitation, and D for drugs. So let's talk about the first acronym, letter of the acronym, the letter H, avoiding the H's. So again, what are the H's? The H's are hypotension, hypertension. What were the rest? Hypotension, hypertension, hyperthermia, and hyperglycemia. Okay? All right, so let's move on to the management of the patients with traumatic brain injury and remembering the first H, avoiding hypotension. Whenever we have a patient with traumatic brain injury, the patient's volume status should be the first thing that needs to be evaluated. And hypotension, if it happens, should be corrected as rapidly as possible. So how do we manage this hypotension? Aggressive fluid administration under CVP monitoring is the first step in the prevention and management of patients with hypotension. Now, after we had adequately resuscitated the patient as far as volume is concerned, if the patient still remains hypotensive, then the management includes giving the patient vasopressors or inotropes to maintain a mean arterial pressure above 65 millimeters of mercury. So, how do we do that? Well, the drug of choice for giving a patient vasopressor is norepinephrine. Norepinephrine, right over here at the bottom. Okay, is favored rather than other drugs such as dopamine because it's much more predictable and consistent in its effect on cerebral perfusion pressure. It has been found out by evidence that dopamine actually leads to higher intracranial pressures. And therefore, the drug of choice to maintain blood pressure after volume has been established is going to be norepinephrine. We want to maintain the systolic blood pressure above 100 millimeters of mercury for patients who are 50 to 69 years of age and higher, meaning to say 110 millimeters of mercury above for patients above 70 years old, or for those who are 15 to 49. It is expected that in managing these patients, we are going to have to rely on an arterial A line to be inserted to monitor the blood pressure and allow for frequent blood sampling. We also would want to make sure that a urinary catheter is initiated to assess the adequacy of renal perfusion. Remember that the kidney requires approximately 20 to 25% of cardiac output. So it actually is the first organ to show the effects of an impairment of problems with perfusion or problems with volume. Okay? All right. So I have another poll. Let's see. 17. Which of these solutions for the management of hypotension is considered a crystalloid? Okay, let me share with you the results. Okay. And let's go ahead and do this. All right, the correct answer is lactate ringers. A crystalloid is a solution in which the crystals can or may form, but is able to diffuse across cellular membranes. So they're the most common fluids used in the healthcare setting. And examples of those of crystalloids are going to be normal saline, lactate ringers, D5W are crystalloids. Colloid is thicker. It's a glue-like substance, like a protein or a starch. And it actually is used primarily to expand the plasma in place of blood. An example of colloids are your albumin, your hetastat, as well as your dextran. So we want to use crystalloids rather than colloids because remember that crystalloids are solutions that contain electrolyte components, and they're able to to enter the intravascular space as well as the intercellular space and interstitial spaces much easier. So, however, there's one drawback in the use of crystalloids in that it lives in the intravascular space for a very short period of time, and it gradually goes into the intracellular as well as the interstitial compartments. The major disadvantage of crystalloids is, again, their residence in the vascular space is temporary. It only stays in the vascular space approximately 1 hour after administration. Okay? And that is the reason why you need to maintain an infusion of a crystalloid in order to maintain blood pressure. So the debate is on colloid or crystalloids. Well, we don't want to use colloids, and the reason that much is because of the fact that it might cause renal damage. All right. So crystalloids are the first fluid of choice in order to maintain a normal blood pressure. All right, further, the most common fluid that we use is going to be saline. As I said, colloids are avoided as they may cause acute kidney injury. D5 or dextrose containing fluids are usually avoided in patients with what they call that, traumatic brain injury or neurological injuries. Why is that? Why is any dextrose containing fluid avoided in patients with head injury? Causes swelling of the brain cells. What's the mechanism for it to cause swelling? What is the mechanism of dextrose causing further cerebral edema? Anybody? Okay. So let's take a look at fluid and electrolyte balance. Whenever we have solutes like glucose, so let's see now that this is glucose, and we're going to infuse them. What's going to happen is that it's going to draw fluid into it. It pulls water. Cecilia is correct. Edwin is correct. It will therefore draw the water or fluid and therefore would increase edema even more. Thus, we avoid any fluid that has dextrose in it. That is also the reason why, well, later on, I'm going to discuss that. All right. So the next H is going to be hypoxia. So we don't want hypotension, and that's the way we manage hypotension. The next thing is hypoxia. Whenever we have a brain injured patients, all attempts at intubation is going to have to include precautions to reduce the chance of worsening a neurological injury until a radiological clearance is obtained. And therefore, we should always have inline neck stabilization of the patient. Now, whenever we are intubating, we want to make sure that we have all these precautions in mind. First, propofol and thiopental may cause hypotension, and therefore they might not be the favored agents in order to assist us with intubation. Succinylcholine or rocuronium are actually preferred over propofol and thiopental. And of course, there are neurologic, ventilation considerations that we have to have. Before we do that, let's go ahead and have a poll. All right. All right. So I see that you're answering the poll. I'm glad to see that. And I'm waiting for the others to respond. We have a 55% response rate so far. We could do better. Okay, so let's go ahead and end the poll. And I'm going to share the results. This is how you responded. And we're going to take a look at what the correct answer is. Okay, so a lot of you said that, let's see, 44% of you chose 7.35 with a CO2 of 40. These are normal blood gas values, right? And the second one, which is 19%, 7.32. This is going to be acidosis. It's respiratory acidosis, correct? And there's one of you that says 7.46. This is alkalosis. And the other one is a normal, a normal blood gas value. So what do we want to have? A normal, hold on. Do we want a normal CO2 value or a high CO2 value or a low CO2 value? Now, whenever we have situations like this is what happens with acidosis, and this is what happens with alkalosis. Whenever you have acidosis, the blood vessels are going to dilate. So we have vasodilation with acidosis. Why is that? If there's a lot of acids right over on the blood vessels, what is the compensatory mechanism of the body? To dilute it. In order to dilute that, you have to draw fluid from other sources in order to increase the volume of blood in the vascular bed. You understand that? So acidosis results in vasodilation. Alkalosis, on the other hand, is going to cause a opposite effect of vasoconstriction. Okay. So when you have brain swelling, brain is swollen, do we want to increase the blood supply or dilate the blood vessels in the brain, or do we want to constrict them? That's my next question. If the brain is swollen, do you want to dilate the veins or do you want to constrict the veins? I mean the blood vessels, not the veins. What do you all think? All right. So Enoch and Winnie and Edwin are all saying, Edwin are saying constrict, and the others are saying to dilate. Now, when you dilate the blood vessels, do you increase swelling even more? You remember the Monroe hypothesis right over here? If we increase this, we are also increasing intracranial pressure. Correct? So therefore, it would not be good to have acidosis in patients with brain injury. What we want to do is actually to hyperventilate the patient up to a PaCO2 of 25 is going to be appropriate for the purpose of reducing intracranial pressure, for as long as we do it in a very brief period of time. So in fact, in order to respond to an emergent increase in intracranial pressure, you could lower the intracranial pressure by actually hyperventilating the patient for a brief period of time. It is still accepted by the Brain Trauma Foundation from 2016 as a recommendation. In addition to wanting to hyperventilate the patient, meaning to say we want the CO2 to be down, we also would want to prevent an increase of oxygen. The reason why we want to avoid high concentrations of oxygen is because it's going to cause a very high increase of oxygen causes cerebral vasoconstriction and therefore would cause further decrease of oxygen supply. How about PEEP? What is PEEP? PEEP is positive and expiratory pressure. And positive and expiratory pressure is actually an intervention to increase oxygenation. But the unfortunate thing is that when we prolong the expiratory phase, what's going to happen is that it has consequences of decreasing blood pressure. So when you decrease blood pressure, you decrease cerebral tissue perfusion, and it also is going to increase intracranial pressure. So we always are going to remember that the application of PEEP or positive and expiratory pressure is going to precipitate an increase in intracranial pressure. In addition, we want to make sure that we are cautious about endotracheal tube tapes. What is the problem with endotracheal tube tapes? Now, usually when this is the head of the patient and this is the neck, we anchor the endotracheal tube right with a circular tape on the neck. What happens when we impede or we apply tapes around the neck? It increases intracranial pressure. So why does it increase intracranial pressure? Okay. So blood coming from the veins and from the brain is drained by veins. Usually veins have valves, but the veins that come from the brain do not have valves. And that's a very important concept to remember. If they do not have valves, They therefore drop blood into the right atrium in a passive manner. So if you constrict this vein, what's going to happen? Blood is now going to be congested more in the brain. And that is the reason why we always want to avoid anything that impedes venous drainage from the brain. Remember that. Okay, so we do not want to have endotracheal tubes that are going to be taped around the neck as much as possible. It should always be cautioned whenever we do that. So care should be taken to ensure that endotracheal tube tapes are not causing venous compression around the neck, and that the head and the neck are kept in a neutral alignment to optimize venous drainage and return. Okay, what I'd like to do now is to go on a break. So let's have a 5-minute break and then come back to continue with this lecture. Let's have a 5-minute break. Number 20. Okay. I hope everybody's back. Are y'all back? Okay, thanks. Let's see. Hmm. All right, so let's go ahead and continue. We had talked about hypotension and hypoxia. So let's talk about hyperthermia, which is the other H in the acronym HEAD. So an increase in body and brain temperature is always going to be associated with an increase in cerebral blood flow. It also increases cerebral metabolic oxygen requirement and the utilization of oxygen, which therefore can result in increased intracranial pressure and therefore further brain ischemia. So it is important thus that we have a measure to control the temperature in these patients, particularly those with hypoxia and ischemia, and remembering that any time that the brain's metabolic rate increases, there's going to be an increasing in swelling. And therefore, we want to prevent the increase of temperature of these patients. In addition to interfering with what do you call this, metabolism, they can also damage the temperature regulating center in the brain, which is the hypothalamus, which may, of course, cause body temperature to fluctuate. So how do we deal with an increase in temperature in patients with traumatic brain injury? What we could do is we could have cooled water or saline solution circulated through external body wraps or special intravascular cooling catheters that can be used to maintain the desired temperature. Now, in the old days, we used to have ice packs. They still could be used, but they are so labor intensive. And actually, it might lead to inconsistent cooling. And that is why we have all these mechanisms now in order to maintain the desired temperature. So I have another poll question. Slide 23. Okay, so the question is, the brain can store large amounts of glucose, true or false? And so let's end the poll. And a lot of you said false. Some of you said true. Okay, so let's talk a little bit about the correct answer. Now, you remember that muscle tissues can store glucose in the form of glycogen. The brain, however, brain tissue is the only tissue in the body that relies on constant bathing of glucose by the cerebrospinal fluid as well as the circulation. And so the correct answer here is false. The brain is unable to save glucose. And that's the reason why when you have a patient with hypoglycemia, what is the first symptom that usually is presented or presents when a patient has hypoglycemia? It is always going to be brain related, isn't it? It is because of the fact that the brain tissue does not store glucose. It has to be dependent upon circulation of blood and cerebrospinal fluid to be bathed with glucose. So one of the problems with traumatic brain injury is hyperglycemia. So you're saying, I thought it was hypoglycemia. Now, what happens whenever we have a catecholamine surge? What is the stress response? The stress response is to release glucocorticoids. Remember that. Now, whenever we have a traumatic brain injury, the catecholamine surge is going to release cortisol, and therefore it leads to a significant hyperglycemia. Hyperglycemia is going to cause the production of lactic acid and consequently, therefore, aggravates cerebral ischemia and head injury. So whenever we have traumatic brain injury, we would like to maintain a blood glucose level between 4 to 8 milliosmoles per liter, or 72 to 145 milligrams per deciliter. In addition to making sure that we treat hyperglycemia, we want to avoid glucose-containing fluids. And of course, the way in which we control or maintain the ideal blood glucose is by the use of insulin. The next acronym of HEAD is E, and E stands for elevate the head. So remember that when you're dealing with a neurologic patient, remember the 4 H's. And now we go to the E, which is the elevating the head. And I said that elevation of the head to around 30 to 45 degree angle can promote venous drainage of the brain and therefore reduce brain swelling. This position actually reduces intracranial pressure and improves cerebral perfusion. So I wanted to pause a little bit because some people think, and in the old days, actually, when Florence Nightingale was alive, she said that whenever you had a patient with a neurological problem, that you should put them in a high Fowler's position. Wouldn't that actually make sense? The old science said that when we position the patient right there on a high Fowler's position, the belief is if this brain is swollen, it will therefore promulgate or encourage the drainage of fluid from the brain and therefore reduce swelling. Well, evidence-based practice have demonstrated that actually the old science was wrong. What was wrong with it? Well, this is what's wrong with it. That when we elevate the patient's head like this and have the patient on a 90-degree angle, like a high Fowler's position, there's going to be flexion of the hips. And when there's going to be flexion of the hips, what's going to happen, therefore, is it increases even more intracranial pressure. How so? Because blood is not going to readily go into the lower extremities because of the flexion of the hip. And therefore, because of the resistance being higher in this area, the resistance is now going to migrate into the brain. All right? Did I discuss that clearly? Why the rationale or the science have changed as far as the belief of positioning on patients with increased intracranial pressure. So always make sure that whenever we elevate the head of the bed to 60 degrees, it decreases cerebral perfusion pressure. This is as a result of the associated hip flexion, which occurs in this position. So make sure that you elevate the head of the bed to around 30 to 45 degrees to promote venous drainage of the brain and reduce brain swelling. Now, in patients with increased intracranial pressure, frequent turning and repositioning may not be possible. So these are interventions that might have to be postponed relative to the increased intracranial pressure. Just wet my throat. Excuse me, one moment. I wanted to pause here to see if you have any questions so far. We have now almost finished the acronym H and E, and we're now going to go to A. But before I go to A, let's see if you have any questions. Okay, no questions. Let's go ahead with the next acronym, and that next acronym is A. A is going to be agitation. We want to avoid agitation, and the way in which we do that is by adequate sedation. And the sedation that we usually favor are midazolam fentanyl combination. Adequate sedation for patients with head injury has many advantages, as it improves analgesia as well as reduces anxiety and agitation, which would increase intracranial pressure. Propofol actually is also another agent that has been found to be favorable in dealing with the agitation of this patient. Reducing stress is important. It is a very important component of brain injury management because it reduces metabolic stress on anybody with an acute brain injury. How does it do that? It rests the brain, and if it rests the brain, you decrease metabolic activity and consumption of oxygen. Therefore, we're going to decrease intracranial pressure that way. Well, we should also make sure, however, that whenever we medicate these patients, what is one of the side effects that usually happens with medicating patients in order to manage their agitation? Hypotension. So therefore, we should have a care to maintain an adequate mean arterial pressure throughout the duration of sedation. And as the patient improves, dosages should be gradually decreased. And the last part of the acronym is drugs. Now, drugs that are going to be very common in patients with brain injury are going to have one particular goal, and that is to decrease intracranial pressure. There are several problems associated actually with an increased intracranial pressure, and one of them is the development of seizures. Now, by the way, seizures that immediately follow the injury or actually are going to be in the early part of the admission is going to be, temporary. However, if seizures occur 2 weeks after the injury, then this is thought to stem from permanent changes in brain structure. So let me repeat that. If the seizure disappears after 2 weeks, that's a good prognosis. That means to say that the seizure was as a result of the direct head injury. But if the seizure lasts for longer than 2 weeks, then it is going to be a manifestation that the seizure is going to be as a result from permanent changes in brain structure or anatomy. All right. So in the past, what have we done to reduce the swelling in the brain? So a lot of you probably in the past have experienced giving steroids. But is steroids actually a good thing for patients with brain injury? The answer to that is no. Because you remember what does steroids do to blood glucose? What does steroids do to blood glucose? Increase. And you remember that 1H, hyperglycemia, that we want to avoid. Therefore, this is going to be avoided. Now, evidence-based practice has demonstrated, and the Brain Trauma Foundation has recommended not giving steroids because steroids haven't been shown to decrease intracranial pressure or improve outcomes. Steroids have demonstrated no benefit at all in the treatment of patients with acute head injury. In fact, it is avoided because steroid-induced hyperglycemia may be detrimental. So talking about seizures, by the way, phenytoin has been demonstrated to have effectiveness in controlling early post-traumatic seizures. And because of its relatively benign side effect profile, levetiracetam has been increasingly employed to prevent post-traumatic seizures. Levetiracetam is also known as Keppra. For those of you, that's a brand name, or Spiritam is the brand name. More conventional agents have also been included to prevent seizures, and that includes propranolol. And usually when initiated within the first 24 hours in patients with moderate to severe head injuries, it has been found out, evidence have shown that propranolol significantly decrease or reduce mortality. And the way in which it decreases mortality is it blocks the catecholamine surge. You remember what we had talked about, the catecholamine surge in the early stages of brain injury. So this is why propranolol is going to be effective. Another drug is nimodipine. And nimodipine is indicated for the treatment or improvement, I should say, of neurological impairments. And this is to decrease spasms of the arteries following subarachnoid hemorrhage, or also in patients with aneurysm. And these actually are going to be armaments that are used in patients with traumatic brain injury. I have another poll, and the question is about mannitol. How many of you have had experiences in in the use of mannitol? All right, so a lot of you have had the experience of using mannitol. And the reason why I ask you about the administration of mannitol is because there has been evidence lately about mannitol. Okay? All right, so this is how you all, you call that, answered. And so let's get out of that and let's talk about mannitol. Mannitol is an osmotherapeutic agent. An osmotherapeutic agent aims to increase the osmolarity of the intravascular space and therefore mobilizes excess fluid from the brain tissue. What did you just say, Dr. Tom? Let us explain that. So let's say now that this is the brain and it is swollen. And we have general circulation here. And we're talking about the veins. We're now going to infuse an agent that has a lot of concentration. Okay. What's going to happen whenever you have an increased concentration of solutes in the vascular space is that there's going to be a consequential migration of fluid because of osmosis. Osmosis is the movement of fluid from an area of lesser concentration to an area of greater concentration. So the fluid from the brain, therefore, is going to be attracted to the venous side, and therefore it's going to reduce swelling. So this is what's called osmotherapy. If intracranial pressure increases, mannitol, which is now called an osmotic diuretic, may be given to decrease cerebral edema and therefore will transiently increase the volume of fluid in the veins that came from the brain and therefore will improve cerebral blood flow. For those of you who have used mannitol, mannitol is so, labor intensive to give. And that is the reason why evidence-based practice have now reduced the use of mannitol. Instead of mannitol, we actually now use hypertonic saline solution because it does the same thing. And when I say hypertonic saline solution, these are saline concentrations of 3% to 24%. Remember that normal saline is what? 9.9%, right? So in these solutions, it is highly concentrated with saline. It's 3% to 24%. And they're used to promote osmotic mobilization of water across the blood-brain barrier. So this is much better now. And the reason is when you use mannitol, what are some of the things that you need to do? Well, number one, you have to make sure that mannitol is warmed because whenever it is in the shelf, it actually crystallizes. So whenever mannitol is in room temperature, there are shards right here, like broken glass. And therefore, before administering, we have to warm it up. Well, actually, here in the United States, we have a warmer all the time. And so we have a mannitol container or an oven that maintains a temperature so that these shards are going to be avoided. And the other thing in the old times is that when you give mannitol, you're always supposed to administer it through an inline filter. Let me repeat that, because there might be some hospitals that might still be using mannitol. When you give mannitol, it has to be given through a filter. And the reason why we filter it is because of the possibility of shards going into circulation. So I'd like to ask of you, how many of you use mannitol with a filter? Can you just indicate yes if you have, if you do? In previous classes, I know that in the international arena, they usually do not use a filter to administer mannitol. Okay, so Solomon said yes, Kevin said no, right? Gio, for example, said no. From now on, think about that. That's the standard here in the United States, is that we always have to make sure that we use actually a, what do you call that? A filter whenever we are administering mannitol. Okay? And then the other thing that is messy with mannitol, or labor intensive with mannitol, is that we always have to make sure that we utilize the inline filter, as I said, and that we always have to make sure that it's warmed before administration. So nowadays, in order to avoid that, and by the way, for those of you who use mannitol, it's so messy that if you drop a drop on the floor, it's so sticky, and therefore it's not a very favorable experience to administer. Okay. Another thing, however, that is going to need emphasis over here is that whenever you are actually giving an osmotherapeutic agent, is you want to make sure that you have a, what do you call that? You monitor the serum osmolarity before you do it, okay? So it is important that before you give mannitol or hypertonic saline, you always have to have a serum osmolarity level drawn 30 minutes before the administration of mannitol. Why is that? It is useful to avoid dehydration because you might be dehydrating the cells too much. It should, usually you will have an order by the physician that says, hold mannitol or hypertonic saline if the serum osmolarity is more than 320 milliosmoles, or sometimes they're safer by saying no more than 300 or 290. Again, it's the preference of the physician. You should never administer mannitol or hypertonic saline without the serum osmolarity result because of the risk of severely dehydrating the cells. Okay? All right. There's also going to be complications associated with hypertonic saline or mannitol, and they are electrolyte disturbances, such as hyponatremia, hypokalemia, and also hypotension. All right, so that ends my discussion on increased intracranial pressure for patients with neurological injury. We're not done yet because I had my alarm so that to make sure that we're able to play our Kahoot and Thus, I'm going to pause before we play Kahoot to see if you have any questions. Are there any questions? For those of you who are new to the game, Kahoot is an online quiz. It's a game. And the object is for you to answer questions as fast as you can. You're going to use your phone to log into a site called kahoot.it. Okay, kahoot.it. And I'm going to show the questions on the screen, and the object is for you to answer as quickly as you can. Okay, so now I'm going to share my screen to show you where to go, kahoot.it, or you can scan this barcode to join. Okay. Okay, it looks like 9 of you are in. You could still join by looking at the screen and answering on the chat. Okay, if you're having difficulty going to kahoot.it. Okay, let's see. Okay, great. Wonderful. Everybody got that correctly. So let's see who was the fastest. And The fastest one was Eileen, Bill, Edith, Gio, and George. Congratulations. Okay, it's 0 to 15. Let's see who got that correctly. Eileen, Bill, Gio, Kevin, and Edith. Very good. Okay, the correct answer is 60 to 70 millimeters of mercury. And Eileen, Bill, Kevin, Edith, and Gio has a streak. Congratulations. Okay, norepinephrine is the preferred agent. And let's see who got that correctly. Eileen, Bill has the highest streak, Gio, Kevin, and Edith. Congratulations. Okay, yes, it's an emergency management for a brief period of time to decrease intracranial pressure. Remember, we want to have hypocarbia, a decrease in carbon dioxide. Eileen, Bill, Gio, Al, Kevin, and Eileen has the highest streak. Congratulations. Okay. Induced hypothermia is a classic standard procedure for patients with return of spontaneous circulation after cardiac arrest. Evidence have shown that it's not effective in patients with traumatic brain injury. So let's see, the correct answer is false. Eileen, Bill, Eileen, Gio, Al, and Kevin. Bill has the highest streak of 6. Congratulations. And let's go to number 7. Okay, 30 to 45 degrees is the correct answer. And Bill, again, Eileen, Gio, Al, and Kevin are in the lead. All right, serum osmolarity should be obtained 30 minutes before the administration of hypertonic saline or mannitol. Bill, Eileen, Gio, Al, and Kevin, congratulations. Okay, it actually attracts fluids from outside of the vascular bed to move to the vascular bed. So the movement of fluid is going to be intracellular to intravascular. And let's see, Bill, Eileen, Gio, Al, Kevin, Bill having the highest week. Okay, because of the diuresis that usually ensues, there's going to be hypokalemia. All right, and C, on the podium, on third place is Gio. Congratulations, Gio. Second place is Eileen, and the first place is going to be Bill. Bill, yes. And runners-up are Al and Kevin. Congratulations, everyone. All right, so let's go ahead and stop this, leave, and okay. Well, I really enjoyed presenting you this information today, and I hope that you were able to gather a lot more of information to improve your practice. I encourage you to please fill out the evaluation for this particular webinar. In an effort to improve our webinars, we want you to provide us with your feedback. Once again, I salute you for making time to attend this particular webinar. I look forward to seeing you again in future webinars. It usually is every Monday until we change the schedule. It has been my pleasure to be with you for the past 2 hours. Keep in touch and have a good day. I will be online to answer any of your questions for the next 15 minutes. Thank you.